Hi everyone, and in this video, I'm going to discuss anti-anginal drug. Now, we all know that angina pectoris meaning is chest pain. What is the reason for chest pain? It is simple that the coronary blood flow is not adequate. Why the coronary blood flow is not adequate? Because there may be obstruction in the coronary artery, and because of that, patient starts having chest pain. So, penultimately, it's the difference between the demand and supply. Basically, we have two types of angina pectoris. One is the classical or stable angina. One more is Prince-Metal angina. So once we know this type of angina, we'll understand what are the drugs used in managing this angina pectoris. So let us start our journey. Anti-anginal drugs. So I told you already there are two types of angina. One is the classical angina. One is the classical, which we see commonly, and one more is the variant angina. So the variant angina. What is the problem in classical angina? The problem is what I am writing is the coronary artery. This is the coronary artery. On the coronary artery, we have a plaque, and that is the atheromatous plaque. So this plaque is called atheromatous plaque. Now, since the plaque or the obstruction is stable, it is also called as stable angina. So this is also called as stable angina. Now, what do you mean by the variant angina? The problem in variant angina, let me write the coronary artery. So the problem in variant angina is the coronary artery is spasmodic. So it is spastic. So there is a spasm in coronary artery. That is why it is also called by one more name, vasospastic angina. And the scientist who discovered this, his name is Prince-Metal. So it is also called as Prince-Metal angina. So here there is atheromatous plaque, and in variant angina there is coronary spasm. Now, what happens in atheromatous plaque or classical angina? Now, when the patient at rest, when the patient is taking rest, he doesn't have chest pain, no chest pain. So when he's taking rest, no chest pain. But when he goes for a walk, he climbs a stair. That is called exertion. So then he starts having chest pain. He starts having chest pain, and that is what we mean by angina pectoris. Usually, this chest pain will be in the center of the heart. From there, it will radiate to the left side of the neck, jaw, and left side of the arm, forearm, like that. Now, this is classically the pain originating from the heart. And whenever the patient goes for exertion, that is walking, climbs the stairs, suddenly he will have severe chest pain. Now, what is the problem here? The problem here is when the patient is at rest, so the blood is still flowing in the coronary, no problem. But when the patient goes for a walk or exertion, what happens is the demand increases. The heart beats faster. There is more requirement of oxygen. If more oxygen is required, more blood should flow. So in the classical angina, the problem is two things. One is the demand that is created by the heart, and the supply which is given by the coronary artery. Now, this angina pectoris is also called as ischemic heart disease. Remember, ischemia itself is a potent vasodilator that would have dilated further. Now, we cannot dilate coronary arteries further in classical angina. What we can do is decrease the demand. So, there are two important aspects what we can do. The major aspect is to decrease the demand and to increase the supply. But the main thing what we can do in classical angina is to decrease demand, and minor thing what we can do is increase the supply. Now there are two types of demand created by the heart as well as blood vessel. So we have the heart and blood vessel. Now heart has a receptor called beta 1. Now when the beta 1 starts stimulating, it will increase the heart rate, conduction, force of contraction. That means demand increases, then the supply should also increase. But that will not happen in angina. But blood vessels, we have the vein. So if you constrict a vein, that increases a load called preload. You have studied this in physiology. When you constrict a vein, there is increase in preload. When you constrict a arteriole, So there is increase in afterload. So the heart has to overcome two demands. One is created by the heart and one is created by the blood vessel. Supply you can also increase. I told you already, coronaries cannot be dilated further because ischemia itself is a potent dilator, but we can still use vasodilators there. Now you have to tell me, how do I decrease the demand and how do I decrease the supply? I mean, how do I increase the supply? Can you take a guess? Yes. How do I decrease the demand and how do I increase supply? Number one, I can decrease the afterload and preload. How do I do that? By using vasodilators. So vasodilators are the one, when they dilate the blood vessels, they can decrease preload as well as they can decrease afterload. So these are called the vasodilators. So that is one targeted therapy what we can do in managing this angina pectoris. So what are the vasodilators we have? The drugs are called as nitrates. So we have the drugs called nitrates and we have calcium channel blockers. So CCBs stands for calcium channel blockers. And we have a drug called nicorandil. So that is also going to cause vasodilation. Now this is target number 1, target number 2 and target number 3. Now what we can do is we can also tell the heart to beat slower. So what is the fourth one we can do is we can use beta blockers. So we can use beta blockers. And number 5, what we can do is there are certain newer drugs which are come in the market and they also decrease the workload on the heart. So we will be discussing under 5 headings: nitrates, CCBs, nicorandil, beta blockers and newer drugs. Now there is a drug called verapamil. It's also a CCB and diltiazem. Now these drugs also work on the heart and decrease the heart rate and conduction. So they can also decrease the workload on the heart. So CCBs can also work on this, particularly verapamil and diltiazem. So this is the drugs what we use in classical angina. Now once I understand that, now the plaque is here. I don't want a plaque to progress further. I don't want plaque to become bigger in size. So I want to avoid this. So for this patient, I will add statins, that is atorvastatin, rosuvastatin, like that, so that the plaque will not progress, the cholesterol will not accumulate. Along with that, for this patient, I will add antiplatelet drugs. So we will be giving antiplatelet drugs as prophylaxis to prevent an MI. So we'll be discussing statins and antiplatelet drugs in the future videos. So this is what we manage. And can I increase the supply? Yes, you can increase the supply. For that, we can use vasodilators, what I mentioned here, that is nitrates, CCBs and nicorandil. So that is one therapy. Now moving on to the another angina, that is called vasospastic and Prinzmetal angina. Now here the patient, even in the rest, he has chest pain. Even when he is taking the rest, he has chest pain. Now there is no exertion, there is no demand. So even in the rest, that means the blood is flowing very less. So what should I do? I have to give vasodilators. So if I want to use vasodilators, what are the drugs? Same thing like what we mentioned: nitrates, calcium channel blockers and nicorandil. These drugs are vasodilators which can be used in variant or vasospastic angina. So here there is pain during rest also. The problem is supply. So you can increase the supply because coronaries can be further dilated because they are spastic here. Now, can we use beta blockers in case of vasospastic angina? Just pause the video and just try to analyze. Can we use beta blockers? Now remember, the arteries are controlled by two important receptors, the alpha 1 and beta 2. Alpha 1 is trying to constrict and beta 2 is trying to dilate. Now if I use beta blocker, they will block the beta, and what happens? Who will take over? Alpha will take over and patient will have severe vasoconstriction. So already in vasospastic angina there is vasoconstriction and that will worsen it further. So that's the reason in variant angina beta blockers are contraindicated. So please keep this point in your mind. In case of variant angina, beta blockers are absolutely contraindicated because they will block beta 2 and alpha 1 will take over. You may ask a question, sir, when you are telling we should not use it in variant angina, why we are using it in classical angina? I told you, in classical angina, what we are worried is to decrease demand, and that is by blocking beta. I told you supply is not a major issue here. Supply is not a major issue, but we can use vasodilators. They can a bit dilate the coronaries, that's it. So that is about the basics to understand what is classical angina, variant angina, what are therapies we use. Many a times patient will come and ask us, sir, should we take the treatment? What happens if we stop the treatment for angina pectoris? The problem is if the patient has classical angina and if the patient has atheromatous plaque, many a times the plaque may rupture and it may lead to MI. So if the prophylaxis is not given, patient may end up with a condition called acute coronary syndrome. Acute coronary syndrome, and it consists of three important complications. One is the unstable angina, then another important condition is the non ST elevation MI, and one more condition is ST elevation MI. So the patient may lead to this complication and there may be sudden death. So that's the reason prophylaxis has to be given with antiplatelet as well as the statin group of drugs. So that is about the introduction about drugs for angina pectoris, and we'll discuss one by one. First we'll take up nitrate and CCBs later, like that. Clear? Yes. So first group of drugs in angina pectoris, what we are going to discuss, they are called nitrates. So they are called nitrates. So what are the nitrates we have? The nitrate what we have is nitroglycerin. Nitroglycerin is also called by another name, that is glyceryl trinitrate. So nitroglycerin is also called by a name, glyceryl trinitrate. How do we give this drug? Now the administration of the drug is in this route. You can give it sublingual. It is given as sublingual tablet, or it is given as sublingual spray. Now where do you use this sublingual tablet or sublingual spray? It is during acute attack of angina. So during acute attack of angina, we use it. Now what is the reason why we give sublingually? We'll correlate with general pharma. Now when we give the tablet sublingually, the drug is absorbed through the lingual vein, directly goes to the heart. There is no first pass metabolism. So that's the reason sublingual route can be used in emergency. And that's the reason why we use it in acute attack of angina. Nitroglycerin can also be used as oral tablet. It is also used as the transdermal patch. So let me write it as TDP. TDP stands for transdermal patch. Now these are used for prophylaxis of angina. So prophylaxis of angina, we give it in this manner, that is tablet. Now remember, nitrates have first pass metabolism, but still we can give them orally. Only thing is we give them at higher doses when we give orally. So this is sublingual, this is oral, and this is the patch. Now we can also give it in intravenous route. Now when do we give this intravenous nitroglycerin? Intravenous nitroglycerin is given in any hypertension emergency. So when you are managing hypertension emergency or a patient having acute heart failure, that is CHF, then we give it in this manner. So a very beautiful drug, nitroglycerin, also called as glyceryl trinitrate. So after that we have another drug, and the name is called isosorbide dinitrate. So it is called as isosorbide dinitrate. Now it is also given in two forms. One is the sublingual and one is oral. So until now you would have understood, if I am giving sublingual, obviously it is during attack of angina, and oral is obviously during prophylaxis. Yes, the third drug is isosorbide mononitrate. So name is isosorbide mononitrate. Please remember, all nitrates have first pass metabolism, that too high first pass. This is one drug which has no or least first pass metabolism. So this is the one which has no or least first pass metabolism. The name is called isosorbide mononitrate. Now the drug is given oral. Obviously, when I tell oral, it is used in prophylaxis of angina pectoris. So you understand the term prophylaxis, that means to prevent attacks. Now, apart from that, we have another drug. So apart from that, we have another drug, that is erythritol tetranitrate, and one more is called penta erythritol tetranitrate. So the name is longer. You can remember, since the name is longer, this is the longer acting nitrate, longer acting. And remember, this is also given oral, that is prophylaxis, and this is also given oral. And one more is amyl nitrate. We don't use it in therapy. It is not used in therapy, and it is a shorter acting nitrate. So these are the nitrate preparations what we have. Number one, the nitroglycerin, also called as glyceryl trinitrate, isosorbide dinitrate. Remember one important point: nitrates are the only drugs which are used in termination of attack of angina, because they can be given sublingually and they go and decrease the preload mainly. So other drugs are isosorbide mononitrate, erythritol tetranitrate, pentaerythritol tetranitrate, which is the longest, amyl nitrate is the shortest. So now I got an idea what are the drugs. What are the drugs. Now once I get an idea, let me understand the mechanism of action, how the drug works. How nitrates work, mechanism of action, very, very important. Now when we give nitrates are metabolized and you will get nitric oxide. Now there is something called mitochondrial aldehyde dehydrogenase. This enzyme plays a major role to convert nitrates into nitric oxide. And these enzymes are present in the vein more than artery. So the enzymes are present main in the vein compared to artery. So which dilation is most common? Venodilation. So they can cause venodilation majorly. Now this nitric oxide which is released, it will act on a guanyl cyclase called soluble guanyl cyclase. Now what is the role of soluble guanyl cyclase? It will convert GTP into a second messenger called cyclic GMP. So GTP will give rise to cyclic GMP. Recently they had asked a question, nitric oxide, how does it work? By increasing cyclic GMP. Please mark it. Now this cyclic GMP inhibits the myosin light chain kinase. Myosin light chain kinase phosphorylation. So the phosphorylation of myosin light chain kinase is inhibited. So when you inhibit that, there is smooth muscle relaxation. Smooth muscle relaxation. Remember, it not only relaxes the smooth muscles of the blood vessel, smooth muscles of the intestine, other smooth muscles. So because if it is a blood vessel we are dealing with, it can lead to vasodilation. Now which dilation is more? Venodilation is more compared to arteriolar dilation. I told you the reason. What is the reason for that? The reason is simple. The enzyme, that is mitochondrial dehydrogenase, is more in the vein. So basically they will ask you these questions. Nitrate, what is the mechanism of action? Now the cyclic GMP action is terminated immediately by into 5-GMP. There is an enzyme which will do this job, and that is called phosphodiesterase 5. So phosphodiesterase 5 is going to convert cyclic GMP into 5-GMP. So this is the mechanism of action of nitrates. Okay. So in the previous slide, we had discussed the mechanical action of nitrates. Here we are going to discuss the uses of nitrates. So when we tell about nitrates, what are the uses? Number one, angina. So we use nitrate in angina, that is the stable angina, or what you call it as classical angina. I told you already, nitrates are predominantly venodilators. So what happens when they dilate the vein? Venodilation, and that will lead to decrease in preload. So that will lead to decrease in preload. So if they ask in the exam, what is the major aim of using nitrates in classical angina? The major aim is that they decrease preload. Now what happens when they decrease the preload? Obviously when you dilate a vein, the blood going to the ventricle decreases. What happens to diastolic pressure? The diastolic pressure decreases. So this will decrease end diastolic volume, or what we call it as end diastolic pressure. Now when you decrease the end diastolic volume or the end diastolic pressure, the subendocardial tissues will undergo very good perfusion. So there is increase in subendocardial perfusion. So the subendocardial tissues, you all know that during diastole they receive more blood flow, so that is increased. And when that is increased, the chest pain decreases. So patient can go for exertion, he can go for walking without any chest pain. And when you do that, there is decrease in oxygen demand. So there is decrease in myocardial oxygen demand. So that is a major role of nitrates in stable angina. Do they work on coronaries? They mainly act on epicardial blood vessels. Now, what do they do in epicardial blood vessels? Let me tell you that. Now, in epicardial blood vessel, I will take an example for you. This is the coronary artery. So, let me draw that for you. Okay, so here, this is the coronary artery branching. Now, let us assume there is a blockage here. So, there is a blockage here, and this zone is called ischemic zone. So this zone is called as ischemic zone. Now when we use the nitrate, so when we use the nitrate, what happens? When we use nitrate, what happens is they will dilate the blood vessels in the ischemic zone. So dilate the epicardial blood vessels in the ischemic zone. This is the non-ischemic zone. This is the non-ischemic zone. That means there is no obstruction there. So here they maintain the tone. So they maintain the tone here. So what happens when the blood flows to the coronaries? The blood flows to the coronaries. They can move towards the ischemic zone more compared to non-ischemic zone. Along with that, the blood vessel which connect the ischemic and non-ischemic, they are called as collaterals. So nitrates open the collaterals. So when you open the collaterals, what happens is the blood will also flow from collaterals into ischemic zone. So these are the advantages why we use nitrates in classical angina. Number one, I will repeat again, they will dilate the blood vessels in the ischemic zone. And number two, they will not dilate the blood vessel in non-ischemic zone, they maintain the tone. Second, they open the collateral. So this is called redistribution of coronary blood flow. So this is called redistribution of coronary blood flow. Right. So the question asked in the exam is, will they increase the total coronary blood flow? No. Whatever blood is coming, they will redistribute to the ischemic and non-ischemic zone, what I mentioned now. So please mention this point. They will not increase total coronary blood flow. Very, very important point. Okay guys, so remember in stable angina there are two actions, venodilation as well as the dilation of epicardial blood vessel, and they redistribute the coronary blood flow such that they open the collateral, They dilate the blood vessels in ischemic zone, they maintain the tone in non-ischemic zone, and they will not increase total coronary blood flow. Now, I think most of you have heard of a concept called coronary steal phenomenon. Yes. Can you tell me which drug can cause that? It is called dipridamole. Now, if I take the example of dipridamole and explain to you, let me write that. Same diagram here. The coronary is here. Okay. So this is the coronary, what we already draw. So here what happens is the ischemic zone, and this is the non-ischemic zone. So what happens when we use a drug called dipridamole? Now, dipridamole is an antiplatelet drug. What happens when you use it? Now, when we use dipridamole, this dipridamole will dilate non-ischemic zone. They will dilate non-ischemic zone because ischemia has already dilated the ischemic zone. It will not dilate further. So they will dilate the non-ischemic. So whatever blood comes, it will be diverted towards the non-ischemic zone, and that is what we mean by coronary steal phenomenon. It is called as coronary steal phenomenon. So usually when we give nitrate, that will not happen. If that happens, we couldn't have given nitrates. So dipridamole is an antiplatelet drug which will produce that. Similarly, the other drugs which produce it are adenosine and a drug called reg adenosine. So these three drugs are used for a testing, and they are used for a testing called cardiac stress testing. So usually we do this cardiac stress testing by treadmill. If the patient will not run, then we use the drugs. Now what does these drugs will do? Dipridamole, adenosine, regadenosine, they are going to cause coronary steal phenomenon and induce the ischemia in the ischemic zone, and you can detect the ischemic heart disease. Now, is there any other drug which can be used for coronary stress testing? Yes, the drug is called dobutamine. The name is dobutamine. Dobutamine acts by increasing the workload on the heart. So remember, the drugs we use for cardiac stress testing are dipridamole, adenosine, and regadenosine. They cause coronary steal phenomenon. And dobutamine will not cause coronary steal phenomenon. It increases the workload on the heart by acting on beta 1 receptor. So this is the correlation I had to tell you when I am discussing the actions of nitrate. So this is what the nitrates will do in stable angina. The question is also asked whether they will do something with arteries. Yes. So when you use them at large dose, they can also cause arteriodilation and decrease afterload. So that is not their major action, that is their minor action. So this is in detail. Simply remember, in stable angina, they decrease preload. Moving on to the other uses of nitrates. Nitrates are also used in the Prinzmetal angina. So Prinzmetal angina. So they can ask you in the exam, what is the major aim? Why do we use them? The reason is they increase the supply. Because in Prinzmetal angina, we all know that there is coronary spasm. So what they do, they cause endothelium independent, endothelial independent coronary vasodilation. Sir, what do you mean by endothelium independent coronary vasodilation? See, endothelium of the blood vessel itself has nitric oxide, that is called EDRF. With that only it would have dilated, but it is not dilating. So we are using a drug which doesn't depend on that process, and it is causing coronary vasodilation. That is called endothelium independent coronary vasodilation. That is a major aim. Why do we use nitrates in Prinzmetal, also called as vasospastic angina? Very, very important point. Now, apart from this, we also use it in acute coronary syndrome. So what are the conditions? Acute coronary syndromes. Yes, obviously they are the unstable angina, non-ST elevation MI, ST elevation MI. Then the next use is they are used in esophageal spasm. So they are used in esophageal spasm, and one more condition is biliary colic. The question asked in most of your exam is, can we use it in renal colic? So just pause the video and try to analyze. Is it useful in renal colic? No, it's not useful in your renal colic. Now acute coronary syndrome, let me write again so that you don't have a confusion. Acute coronary syndromes, it can be used in unstable angina. So the non-ST elevation MI and ST elevation MI. So these are the uses. Apart from that, I told you it can be used in the management of CHF, both acute and chronic CHF. These are also used in the management of hypertension emergency, that is nitroglycerin, which is given IV. IV nitroglycerin can be used. Then we can also use them in a poisoning called cyanide poisoning. So nitrates can be used in cyanide poisoning. So these are the major uses of nitrates. Let me repeat again. In detail, you should know how they work in angina pectoris, particularly classical angina. Then prinzmetal angina, they mainly cause endothelium independent coronary vasodilation. Then acute coronary syndrome, esophageal spasm, biliary colic, acute and chronic CHF, both hypertension emergency as well as cyanide poisoning. So these are the uses of nitrates. So until now we have discussed the mechanism of action, the drugs and the uses. Now what is the adverse effect of using nitrates? Let us analyze that. So adverse effect of nitrates. Adverse effect of nitrates. Now it's easy to remember what are the things. Let me tell you. Number one, they are vasodilators. So what happens when you dilate the blood vessels in the head? Obviously, patient will develop headache. When you dilate the blood vessels of the head, headache. Then when you dilate the blood vessels of the face, what will the patient experience? Flushing. Flushing. Now when you dilate the blood vessel, what happens to the BP? Obviously, the BP will come down, hypotension. And whenever the BP falls, what is the reflex mechanism? What we have is reflex tachycardia. So they can increase the heart rate. Now if the reflex tachycardia is seen, what we do is we add nitrates. With the nitrates, we add beta blocker, or we use the group called verapamil. Now what do? They decrease the heart rate. So beta blocker or verapamil, they decrease the heart rate. So if reflex tachycardia is a problem, along with nitrate, you can add beta blocker or verapamil. They can take care of reflex mechanism. Another important aspect, what we see, headache, flushing, hypertension, reflex tachycardia, is constipation. Now, can you tell me why do they cause constipation? Because they are smooth muscle relaxant. That is the reason, if you see the uses, we had used them in esophageal spasm and biliary colic. The reason is they are smooth muscle relaxants. But they are not shown to be effective in renal colic, that's why we didn't use it. And since they are smooth muscle relaxant, they can decrease the motility of small intestine and they can cause constipation. So once I know the cause constipation, they can cause a condition called methemoglobinemia. Methemoglobinemia, and we take the advantage of this to manage a condition called cyanide poisoning. Let me explain how it works in cyanide poisoning. Very beautiful concept. Now whenever a patient is taking cyanide, what happens? We give the patient either sodium nitrite or we give amyl nitrite. So these will make the hemoglobin methemoglobin. Now this methemoglobin will combine with cyanide to form cyanomethemoglobin. So it forms to cyanomethemoglobin. For that, we add something called thiosulfate. So when we add thiosulfate and cyanomethemoglobin combine to form thiocyanate. And this thiocyanate is water soluble and that will throw away the cyanide out. So this is an outdated method for managing cyanide poisoning. Nowadays, if they ask in the exam what is the drug of choice for cyanide poisoning, drug of choice for cyanide poisoning. Yes, any guesses? Yes, it is nothing but hydroxocobalamine. It is hydroxocobalamine. Now, why do we give hydroxocobalamine? Cyanide combines with hydroxocobalamine, you get cyanocobalamine. Cyanocobalamine is water soluble and it is excreted in the urine. That's it. So the drug of choice is hydroxocobalamine. You can also use sodium nitrate or amyl nitrate, but the effect is not that much. So the methemoglobinia caused by nitrates is used in the management of cyanide poisoning. And repeat again, they cause headache, flushing, hypertension, reflex tachycardia, constipation, and methemoglobinemia. Apart from that, when we use nitrate continuously, there is a chance they develop a problem called tolerance. Now, what do you mean by tolerance? If I give the drug repeatedly, the drug will not work. So what you should do, either you should increase the dose or what you can do is you can give a drug-free interval. So in case of nitrate, what we can do is you can give drug-free interval. You just imagine, suppose I take a class from 9 o'clock to evening 9 o'clock without any break. You will develop tolerance to pharmacology. So what should I do? I should give break in between. Same thing, nitrate can develop tolerance. So to avoid it, so what should I do? I should give drug-free interval. Drug-free interval. So I cannot give it continuously. Suppose you are giving the drug 3 times a day. So what we do, when we prescribe, we will skip the last dose. So we'll tell the patient to take the morning and afternoon dose, and we tell the patient not to take the evening dose. Or we will not tell the patient only, we tell the patient you take morning and afternoon, that's it, fine. Second is, if the patient is wearing a patch, now tell me, you pause the video and tell me, when should we remove the patch? So patch will be applied and it will be working 24/7. So when should the patient ideally remove the patch? Is it in the morning or in the night time? Take a guess. Obviously, it should be in the night time because night time you will not be so much active, but in the morning is so much active. So morning he has to apply. So remove the patch at night. Remove at night time. Another practical problem is, suppose a patient removed at night time and in the midnight or 1 o'clock he starts having chest pain. Then what should I do? What should I instruct a patient? Should I tell the patient you apply the patch again? Now patch will not work immediately. So what should I tell? If he gets an attack in the night, he should take a sublingual tablet. So that's the reason I told you patch is for prophylaxis, sublingual is for attacks. Clear? So that is how we avoid the tolerance. Another important problem what happens is dependence. So when we use this nitrate, the coronaries depend on nitrates to dilate. So coronary vasodilation depends on nitrates. If you give nitrate, the coronaries will dilate. But when you suddenly stop nitrate, there is a chance of coronary spasm. So there is a chance of coronary spasm and patient may end up with MI to the casualty. So the message here is, when a patient is on long-term nitrate, you should not stop it abruptly. So when you instruct a patient, tell him never stop it abruptly because it may produce dependence. Now, another disease what we see with nitrate, particularly people working in a nitrate factory, nitrates are actually explosives and they are used in batteries or something like that. Those employees who work in these industries which contain nitrate, when they go for the work on the Monday, they get exposed to the nitrate. Now, nitrates are vasodilators and they cause vasodilation and they will have headache on Monday. But as the day they start working, the nitrate develop tolerance and the headache is gone. The headache is gone. But again, when the Friday is over, they will go to the home. So there is nitrate free interval on Saturday and Sunday. Again, when they come back to the work, they will have again headache, and that is called Monday's disease, which is seen with nitrate products. Not so important, but this is one application to tell you what are the adverse effects of nitrates. So let me recap the adverse effect of nitrate: headache, flushing, hypertension, reflex tachycardia, and constipation, methemoglobinemia, tolerance, and dependence. These are the problem what we face with nitrates. Now, coming back, what is the drug interaction commonly asked? Drug interaction, I told you. You just tell me, can I combine nitrate plus beta blocker? Yes. Now, when nitrates are used, they can cause reflex tachycardia and that can overcome by beta blocker. Can I use nitrate plus verapamil? Yes, you can use them. Now, most commonly asked in your exam is, can I combine nitrate plus sildenafil group of drugs or tadalafil, vardenafil, like that drugs? Now, what is the mechanism of action of nitrate? Nitrates stimulate soluble guanyl cyclase and they increase cyclic GMP. And we know that cyclic GMP is broken down into 5-GMP by the enzyme phosphodiesterase 5. Now, this is responsible for vasodilation. Now, what happens when I combine nitrate and sildenafil together? Sildenafil is going to inhibit phosphodiesterase 5. So, when we give them together, there is so much increase in cyclic AMP. So, the combination causes severe hypotension. So, when there is severe hypotension, it can lead to reflex tachycardia and patient may end up with MI also. So the major problem is severe fall in BP can happen, reflex tachycardia, and patient may die because of MI. Now, what happened is sildenafil came around 1980s or 90s. At that time, nitrate was used, and patient used to take sildenafil, the Viagra for erectile dysfunction. So they started using this without consulting the doctors, and many patients have collapsed in the bed only because of severe fall in BP, reflex tachycardia, and MI. So that's the reason they keep on asking this combination, whether it is rational or not. So what is the reason for that? So that is about the drug interaction. So nitrates are very, very important when we come across angina pectoris. Remember the mechanism of action, they increase cyclic GMP. Remember the uses, then what are the drugs and their adverse effect. So in the next, I will be discussing calcium channel blockers. Okay, so discussing the other anti-anginal drugs, the next one is the calcium channel blockers. Calcium channel blockers. Yes. So in short, I will be calling them as CCBs. Now, when we talk about calcium channels, so calcium channels, basically there are three types of calcium channel. The L type. So what is the meaning of L type? It is nothing but long lasting. T type meaning transient, and N stands for neuronal. So what is we are discussing calcium channel blockers? They block L type of calcium channel. Now what is the role of L type of calcium channel? It is mainly present in the heart as well as in the smooth muscles as well as blood vessel. T stands for transient. Example of T type of calcium channel blocker, there is a drug called flunarizine and that is used in migraine prophylaxis. N type of calcium channel is blocked by certain drugs called pregabalin, gabapentin, which we will be discussing in CNS. Okay, so that we'll discuss in CNS, but our major focus in this discussion will be to block L type of calcium channels. Now, what do they do? What is the role of calcium? So let me write a smooth muscle for you. This is the smooth muscle. Right? So, whenever the action potential comes, the calcium moves inside. there is stored calcium that will also come to the picture, and this calcium will combine with a compound called calmodulin. Now there is myosin light chain kinase, and that will undergo myosin light chain kinase phosphorylation. Now this phosphorylation will convert myosin into myosin phosphorylated, and this will combine with actin, and that will cause contraction of smooth muscle. Now, already I have discussed with you nitrate. What do the nitrate will do? Nitrates will not allow the myosin light chain kinase to undergo phosphorylation. They increase cyclic GMP, and that will inhibit this step. And this is done by the nitrates through nitric oxide. Okay, that is one point. Now, if calcium comes, then only the contraction occurs. So the CCBs will not allow calcium to enter. They block the calcium channel. So these are the two major actions. What is the action of calcium calmodulin? Is to convert myosin into myosin phosphorylated by activating myosin phosphorylation. So that is also going to cause contraction. So if I don't allow calcium to enter, there is no smooth muscle contraction. So that is the basics. Now, once we understand the basics, let me tell you one more important point. In calcium channel blockers, in CCBs, in calcium channel blockers, basically we have two important types of drugs. They are called non-DHPs. So non-DHPs meaning is non-dihydropyridines, and we have one more group of drug. They are called as dihydropyridines. So they are called as dihydropyridines, and in short I will be writing them as DHPs. And DHP, one important drug I just want to tell you is nifedipine. So the name is called nifedipine. And remember, all these dihydropyridines, they end with dipine. Now the major action of these are on the blood vessel. So their major action is on blood vessel, and you tell me, when you act on blood vessel, they relax the smooth muscle in the blood vessel. So what do you see? Vasodilation. Now when you cause vasodilation in the blood vessel, what is the BP is going to happen? The BP is going to fall. So when the BP falls, what is the reflex mechanism? There is reflex tachycardia. So there is reflex tachycardia, what we see with dihydropyridines. So they cause smooth muscle relaxation, the blood vessel will dilate, and the BP falls, reflex tachycardia. So their major action is only on blood vessel. Will they act on the heart? No, they don't act on the heart. Come to non-dihydropyridines, there are two major drugs. One is called verapamil. One is verapamil, and one more is called diltiazem. So we have the drug verapamil, and one more is diltiazem. Now these drugs have action on two tissues in CVS. One is in the heart and one is in the blood vessel. So what will they do in the heart? They decrease the heart rate, they decrease the conduction, and they decrease the conduction, and they decrease the force of contraction. So this is what they do. Now what do they do in the blood vessel? They are smooth muscle relaxant, so they can cause vasodilation, and they decrease the blood pressure. The question asked is, will they cause reflex tachycardia? You pause the video and just try to analyze it. Will they cause reflex tachycardia? No, because they themselves suppress the heart. So they are cardiodepressants. They decrease the heart rate. Now remember, compared to verapamil, who will act more on blood vessel? More action on blood vessel is with dipins. Who will act more on the heart is with verapamil and diltiazem. They act more on the heart. So this is the difference between DHPs and non-DHPs. Remember, very, very important point. Verapamil, diltiazem, they can act on heart and blood vessel, but there is no reflex tachycardia. But dipins, they act only on blood vessel, and they decrease the BP, and you see reflex tachycardia. The question here is, can we combine verapamil, diltiazem or diltiazem? Let me not confuse you. Just I will ask you, can I combine verapamil plus beta blocker together? So yes or no? Please comment. Pause the video and just comment. Yes. Now verapamil also decreases the heart rate, conduction, force of contraction. So same thing is also done by beta blocker. So the combination should not be used. No, because both of them will cause bradycardia and AV block. And severe bradycardia and severe heart block can happen. Never use them together. So we understood the mechanism of action of CCBs and what are the group of drugs. So once we understand that, let me write the uses. So what are the uses of CCBs? Uses of calcium channel blockers. Now let me tell you about non-DHPs. What are their uses? The non-DHP drug is verapamil. So verapamil is used in angina, hypertension, and arrhythmia. So it is used in angina, hypertension, and arrhythmia. So what about diltiazem? Diltiazem is also used in these conditions: angina, hypertension, arrhythmia. What are the special uses of verapamil then? Apart from this, what are the other uses of verapamil? Verapamil is also used in migraine prophylaxis. It is used in migraine prophylaxis. One more condition where we use verapamil is a condition called nocturnal leg cramps. So verapamil is used in nocturnal leg cramps. Is there any other use of diltiazem apart from this? Yes, it is used in pulmonary hypertension. So it is used in pulmonary hypertension. Now please remember one more point I want to add. For pulmonary hypertension, we use inhaled nitric oxide. Very, very important point. Inhaled nitric oxide is used in pulmonary hypertension in neonates. Very, very important point, mark it. So this is what I mean by lateral study. You'll understand here. So this is about verapamil and diltiazem, and they belong to which class of antiarrhythmic? They belong to class 4 antiarrhythmics. So they belong to class 4 antiarrhythmics. So once I understand the non-DHPs uses, let us understand the uses of dihydroprudence and how do they end with dipin. Now the main drug is nifedipine. Nowadays what we use nifedipine is used as sustained release. Now the problem with immediate release is reflex tachycardia is the major problem. So sustained release will release it slowly, and we use it in two conditions. Number one, hypertension in pregnancy. So it is used in hypertension in pregnancy and it is safer. Second, it is used for uterine relaxation. It is used as uterine relaxant in what? Where do you want to relax the uterus? In case of preterm delivery. It is used as uterine relaxant in preterm delivery, that is nifedipine sustained release. The other dipines are amlodipine. Amlodipine, the major use is in hypertension. The advantage of amlodipine is less chance of tachycardia. Then we have nicardipine and a drug called clevidipine. Nicardipine and clevidipine. Nicar and clevi, these are IV preparations. Now, obviously, when the drug is IV, we cannot give to the patient every day for hypertension. So we use it in emergency. These are the drugs used in hypertension emergency. Hypertension emergency. Then we have a drug called nitrendipine. Nitrodipine specialty is it also releases nitric oxide. It causes nitric oxide release. Now you just guess a drug, a beta blocker which can release nitric oxide? Yes, it also starts with N. Yes, it is called nebivolol. So the next one is nimodipine. Nimodipine specialty is it can cross blood-brain barrier. So BBB stands for blood-brain barrier, it crosses. Now where do you use it? It is used for a condition called subarachnoid hemorrhage. So it is used in subarachnoid hemorrhage. You may ask a question, sir, subarachnoid hemorrhage, already the bleeding is occurring, and if you dilate a blood vessel, will it not increase the bleeding? Now remember, whenever the bleeding is occurring in certain part of the brain, there is reflex vasospasm. So whenever there is reflex vasospasm in the vital areas of the brain, so there will be irreversible damage. So this nimodipine will cause vasodilation and prevents this reflex vasospasm. And advantage is it can cross the blood-brain barrier. And remember, nimodipine for Nimans. Where do you use? Where is Nimans? Nimans is mainly for neurosurgery, that is trauma, psychiatry. So Nimans for subarachnoid hemorrhage. So there are so many N's here: nifedipine, nicardipine, nitrendipine, nimodipine. Please differentiate them. Nifedipine, most of you know. Nicardipine, cardiac emergency, hypertension emergency. Nitrendipine, nitric oxide release. Nimodipine, Nimans for subarachnoid hemorrhage. Now remember, CCBs are used in peripheral vascular disease, that is Raynaud's disease. Raynaud's disease. CCBs are drug of choice. Please note down this. CCBs are drug of choice for the peripheral vascular disease, that is Raynaud's disease. So these are the uses of CCBs. So I have given them separately where to use: verapamil, diltiazem, then nifedipine, amlodipine, nicardipine, clevidipine, nitrendipine, nimodipine. Right? So this is the point. So now I know the mechanism of action, I know the different CCBs, and I know the uses. What is the adverse effect then? What are the adverse effect of calcium channel blockers? Yes, obviously when they are a vasodilator, remember CCBs are predominantly arteriolar dilators. So in the exam, if they ask you which dilation do they produce, arterial dilator, what about nitrate? They are predominantly venodilator, predominantly. Now the adverse effect is they can also produce headache. So that's the reason you should not give it in acute attack of migraine, but you can use it in prophylaxis. In acute attack of migraine, already the blood vessels are dilate. If you give CCBs, it will worsen. But you can give them in prophylaxis because vasoconstriction is the triggering factor for vasodilation, which will lead to acute attack of migraine. So we don't want that vasoconstriction to occur. That's the reason we give it in prophylaxis of migraine, that is verapamil. Now, same problem like nitrate flushing, then hypotension. Whether it causes reflex tachycardia or not, I have explained that. If it is DHPs, they cause reflex tachycardia. If it is non-DHPs, no reflex tachycardia. So I'll write that here. DHPs, they can increase the heart rate. Non-DHPs, they decrease the heart rate. Yes. Then they can produce constipation. Why? Because they are smooth muscle relaxant. But one important problem with them is very, very important. They can produce gum hyperplasia. They can produce gum hyperplasia. And second one is they can produce the pedal edema. So these are the two important image-based questions they can ask in the exam. Which antihypertensives can produce gum hyperplasia and pedal edema? They are nothing but the calcium channel blockers. Now these CCBs are contraindicated in a patient with GERD. gastroesophageal reflux disorder. Can you tell me why? The problem in GERD is the esophageal sphincter is lax, and that's why the acid is coming back to the esophagus. When I use CCBs, they are muscle relaxant, that is smooth muscle relaxant. They will relax the esophageal sphincter further and it will worsen the GERD. So that's why we don't use it. So that is about calcium channel blockers. Yes, so once we understand these nitrates, calcium channel blockers, we'll discuss one more new drug that is called nicorandil. The third drug what we are going to discuss is called nicorandil. The name itself has dil, heart. Nicorandil is a potassium channel opener. So that is a major mechanism of action. And also it causes nitric oxide release, and that is the minor mechanism of action. Now most of your exam question is, what is the mechanism of action of nicorandil? It's a potassium channel opener. You may ask a question, how come potassium channeling open? If you open the potassium channel, how does it benefit? Now this is the cell, a smooth muscle of a blood vessel. You know that the cells are negative inside. The positive ion that is present is potassium. Now what happens when you open the potassium channel? The potassium exits and the cell will become more negative. So that is called hyperpolarization. Now you tell me, if you hyperpolarize the cell more, will the cell is excitable or less excitable? Obviously it is less excitable, and if it is a smooth muscle, it will lead to smooth muscle relaxation. So that is the role of nicorandil. It's a potassium channel opener and it causes vasodilation and decreases preload and afterload and some coronary vasodilation. So that is nicorandil, very, very important, guys. Moving on to fourth category of drugs, they are called beta blockers. So beta blockers, for example, bisoprolol, metoprolol, atenolol. So these are cardioselective beta blockers which are preferred. Now beta blockers are used in classical angina. Now why do we use them in classical angina? The reason is simple. They decrease the heart rate, they decrease the conduction, they decrease the force of contraction. What happens if you do this? This will decrease the workload on the heart. So when you decrease these things, this will lead to decrease in workload of the heart, and when you decrease the workload, obviously the oxygen demand decreases. So that is a major action of beta blockers. But beta blockers are contraindicated in Prince metal angina. I have explained that in the beginning why they are contraindicated. When you block beta, there is unopposed alpha action causing vasospasm. Already in Prince metal there is vasospasm that will worsen it further. And please remember, beta blockers have specialty. Beta blockers are the only drug which increases life expectancy in angina patients. In angina patients, the only drugs which increase life expectancy, that is patient survival, is beta blockers. What is the reason for that? Now if the patient is already on a beta blocker, and suddenly gets acute coronary syndrome, he has two important advantages. Beta blockers decrease the arrhythmia risk. They decrease the arrhythmia, and also they decrease, if there is a MI, they decrease the infarct size. So these are two advantages, and that's why they are known to increase life expectancy in angina pectoris patient. And never use them in Prince metal angina. So these are the four drugs I have to tell you which are used in the management of angina pectoris. So moving on to the last category of drug, and they are called the newer drugs. So we'll be discussing the newer drugs in angina pectoris. Newer drugs. So what are the newer drugs? Number one, we have a drug by the name ivabradine. The name is ivabradine. Now, what is the mechanism of action of ivabradine? It is known to inhibit a channel in the heart, that is SA node particularly, that is funny sodium channel. So funny sodium channel at SA node. So what happens if you inhibit a funny sodium channel in SA node? The heart rate decreases. So obviously when the heart rate decreases, the oxygen demand decreases. So please remember, majority of the newer drugs are going to decrease the oxygen demand. So it inhibits funny sodium channel in SA node and decrease the heart rate and decrease the oxygen demand. Now, where to use it apart from angina? It is used in stable angina as well as in management of CHF. What is the adverse effect of the drug? Ivabradine can produce vision impairment. It can produce vision impairment. And the vision impairment that is told by the patient is called luminous phenomenon. It is called as luminous phenomenon. So patient will complain of brightness or halos. So that is called luminous phenomenon. And remember the drug here. So IV stands for impairment of vision. BRAD stands for bradycardia, decreased heart rate. I for inhibits, N for what? Sodium. Which sodium? What comes out after E? F, funny sodium channel. I repeat again. IV for impairment of vision, BRAD for bradycardia, I for inhibits, N for sodium. Which sodium? The one which comes after E, F, that is funny sodium channel. That is one drug, ivabradine. Moving on to the second drug. The name is called ranolazine. The name is called ranolazine. So what is the mechanism of action? It inhibits late sodium channel. Now what is the role of late sodium channel? I will explain here. In the heart, this is the cardiac tissue. Late sodium channels, when the sodium enters inside, these are late sodium channels. So these sodium which are entered are exchanged with calcium. So these late sodium channels are exchanged with calcium, and more the calcium, this calcium is responsible for contraction, that means increased workload on the heart. So it can cause angina, arrhythmia, all these cases. So our major focus is to block this late sodium channel. If you block that, calcium will not enter. If calcium will not enter, the force of contraction decreases and angina decreases. So that is the mechanism how it is useful. So it inhibits late sodium channel. By inhibiting that, it decreases calcium load on the heart. So you know that calcium, if it is more, it requires more binding, and more force of contraction means more oxygen. So by decreasing the calcium load, it decreases the oxygen demand. So that is the mechanism of action of ranolazine. You can remember like this. Ranolazine, what does it do? N for sodium, which sodium? La for late sodium channel inhibitor. The advantage of this is no effect on heart rate and BP. You check all other drugs what we have discussed till now, nitrate, nicorandil, they either decrease BP, increase BP, or they decrease heart rate or increase heart rate. They have some effect on the heart rate, I have explained already, but this drug doesn't affect. Suppose patient has bradycardia and you cannot give ivabradine or beta blocker, then you can use it. Or patient has hypertension, you cannot give nitrate, then you can use it. Now where to use it? It is used in stable angina. Because in this the problem is the demand, so it decreases oxygen demand. The name is ranolazine. Moving on to the third newer drug. It is called trimetazidine. It is called trimetazidine. It is an inhibitor of PFOX. So what is PFOX stands for? Partial fatty oxidation inhibitor. Partial fatty oxidation inhibitor. Yes. Now, what happens in ischemia? If there is ischemia in the heart start utilizing fatty acid. And fatty acids require more oxygen to yield certain energy. So if I block the fatty acid oxidation, the heart start utilizing glucose. And glucose require lesser oxygen. So that is the reason why we use trimetazidine. So when I use trimetazidine, heart start utilizing glucose and it can provide energy with the consumption of less oxygen. So you read the name tri for triglyceride, met for metabolism inhibitor. That is fatty oxidation inhibitor. That is trimetazidine. It is also used in stable angina. Okay, so these are the drugs what we use in the management of angina pectoris. Number one, nitrate. Number two, CCBs, nicorandil. Number four, we have the beta blockers. Number five, newer drugs. Newer drugs, we have uvabradine. Then we have ranolazine and trimetazidine. Okay, so moving on to complication of angina pectoris. So it can lead to a problem I told you already, the acute coronary syndrome. So patient may end up with acute coronary syndrome. So we have a complication called the unstable angina. So unstable angina, it is nothing but the plaque is unstable and it is progressing. And one more is non-ST elevation MI. And one more is ST elevation MI. So this will be discussed in detail in medicine. I'm just giving an idea. What is the ECG changes and cardiac markers in these cases? In unstable angina, the ECG changes are present. You will see the ECG changes and cardiac markers are normal. In non-ST elevation MI, you will see ECG changes. Particularly, you will see ST depression. And cardiac markers are elevated. In ST elevation MI, as the name suggests, ST is elevated in ECG. ST segment and cardiac markers are raised. So this is a differentiating point: unstable, non-ST elevation MI and ST elevation MI. Now, how do you manage these cases? Now, remember, when a patient has unstable angina or a patient has non-ST elevation MI, they are managed similarly. So, patient will come with chest pain, so we use morphine, a opioid analgesic. The question is, why do you use morphine only? The morphine is known to decrease sympathetic outflow. So whenever the patient has chest pain, he will have anxiety and sympathetic overactivity, that is decreased by this. It also decreases anxiety. And it's a venodilator. Remember, morphine is a venodilator, so it will shift blood from pulmonary to systemic circulation. And many a times during MI, patient may have pulmonary edema because of heart failure, and that can be taken care, and also it decreases pain. So these are reasons why morphine is preferred. Second, you have to give oxygen, and then nitrates. So nitrates, usually what we give is nitroglycerin, that is sublingual. Now remember, when you are using nitrate, very very important point, if a patient has hypotension, never use nitrates because they themselves cause hypotension. Then we use antiplatelet therapy. Antiplatelet. So what we use is not a single therapy, we use dual antiplatelet therapy. So one is aspirin. So what we use aspirin is a low dose aspirin. So it is between 162 to 350, so 325 milligram. So for that we can add clopidogrel. The loading dose of clopidogrel will be 300 milligram. So this is the commonly used combination. Now, if clopidogrel is not available, you can use prasugrel. If it is not available, you can use ticagrelor. So these are the other options of using dual antiplatelet therapy. So simple meaning you need to understand is MONA. Yes. So morphine, oxygen, nitrate, antiplatelet therapy. Now along with that, do we use any other drug? Yes. We use IV beta blocker, that is metoprolol. What is the advantage of using metoprolol? Two important advantages. It can decrease the risk of arrhythmia during MI. If there is MI, it can decrease the infarct size. Now we also start low molecular weight heparin. And what is the advantage of low molecular weight heparin? So usually what we give is enoxaparin. The advantage is certain times what happens, the thrombus may progress or thrombus may emboli. So those complications can be stopped by this heparin, that is low molecular weight heparin. Along with that, we add statins and we can give ACE inhibitor or ARBs. These are the additional therapies. Now please remember mainly MONA. Now should we use thrombolytics is a bigger question. Should we use thrombolytics in a patient with unstable angina or non-estivation MI? No, it is contraindicated. Very, very important point. In unstable angina as well as non-estivation MI, thrombolytics are absolutely contraindicated because you have time, patient go to the cardiac center, you can undergo angiography, then you can go for stenting depending on the block. Or if blocks are multiple, you can go for bypass, that is decided by the cardiologist. So these are the drugs what is commonly prescribed when there is acute coronary syndrome: morphine, oxygen, nitrate, antiplatelet, dual antiplatelet therapy, metoprolol, low molecular weight heparin, statins, ACE inhibitor, thrombolytics are absolutely contraindicated. Now what about the management of ST elevation MI? ST elevation MI, the problem in ST elevation MI is the coronary artery is completely blocked. So if you delay the treatment, the cardiac tissue will die further and it may cause irreversible damage. Patient may have arrhythmia, heart failure, and he may die in the way. So ST elevation MI, whatever we give in the unstable angina, non-estivation MI, their drugs are same. Same drugs are used as in non-estivation MI. As in non-estivation MI. So what is important is thrombolytics. Should we use thrombolytics or not? Now it depends. Suppose a patient has chest pain. He comes to the medical contact. He comes to a hospital and that hospital doesn't have a facility for percutaneous coronary intervention and they have to be referred to cardiac center. Now you have to refer the patient from there to cardiac center. You have to refer the patient to cardiac center. So you have to decide whether the patient can reach that within 2 hours or he can reach more than 2 hours. If the patient can reach the cardiac center within 2 hours, that is 120 minutes, don't give thrombolytics. No thrombolytics. Because if he can go within 2 hours, the cardiac center will manage him. They will start angiography and they can put a stent or bypass depending on what the patient risk is. If the patient cannot reach more than 2 hours to the cardiac center, that means more tissues will die and patient may die in between because of arrhythmia and heart failure. So here I need to take a risk. What is the risk? Bleeding. What is the benefit? Patient will survive. So that's the reason I have to give thrombolytics here. So this is the one decision what we have to make in ST elevation MI. Otherwise, the drugs was discussed for ST elevation MI, non-ST elevation MI, unstable angina are same. Only thing is the indication of thrombolytic changes. So I have told you here. So guys, this is what the anti-angina drugs, and I told you the basic difference between classical and the variant angina. What are the drugs? Nitrates, then CCBs, nicorandil, beta blocker, newer drugs. Along with that, prophylactically we use the antiplatelet drug, statin therapy, and I discussed in detail nitrates, CCBs, and nicorandil. Beta blockers we have discussed in ANS pharmacology. Newer drugs, please keep the mechanism of action very, very important. Ivabradine, funny sodium channel, ranolazine, late sodium channel, trimetazidine inhibits what? Fatty acid oxidation, and then the management of acute coronary syndrome. This is what we have discussed in this video. Thank you all.